Hyewon Lee of Yonsei University from South Korea. Today, I'm going to have a presentation about how mothers' work-family gains influences their children's communication skills, dual mediated by mothers' permissive parenting practices and children's media dependency. Traditionally, women's role is considered to do houseworks and raise children, but these days, women get into the job market even if they have children. As the same for Korea, Korean women's employment rate before and after their childbirth has been continuously increasing. It shows that nowadays, mothers are handling their career work and family work simultaneously more than before. Consequently, mothers experience work family conflicts and gains during juggling their various roles more than before. While work-family conflict refers to the role conflict between the jobs and the family work, the work-family gains refers to the role satisfaction that can offset the cost of performing various roles at work and at home, like promoting self-esteem or getting credit for both competent worker and as a dedicating mother. In accordance with the expansion approach on work-family gains, family activities not only decrease energy loss from performing various roles, but also produce more energy through supportive and sympathetic atmosphere of family in the process of performing various roles. In this research, I studied how this mother's work-family gains influence children's communication skills. Children's communication skills are one of the 6 fundamental competencies that the Ministry of Education in Korea selected to intensively develop during elementary school education courses. As children's age increases, children get used to more socialized speech and less egocentric speech, and learn diverse communication skills that can apply to diverse situations based on their past linguistic experiences. These past linguistic experiences mean linguistic interactions with other people. The development of communication skills processed through interactions with family, peers, teachers, and other environmental factors you can imagine. Children can develop their communication skills by interacting with their parents or negotiating with their peers for toys or how to play. In this study, we used Bronfenbrenner's ecological approach for the theoretical background of our study. According to ecological approach, individual development is affected by surrounding environmental factors divided with several layers of systems, like the microsystem, the mesosystem, the exosystem, and the macrosystem. Among them, we focus on the microsystem and the exosystem. First, microsystem refers to environmental factors that individuals directly interact with, like family, friends, or schools, like that. Like children daily interact with their family members, and these daily interactions can influence children's development. And the exosystem refers to the environment factors that do not directly interact with individuals but indirectly affect individual development. For example, parents' workplace and older siblings' school class for children can be the exosystem, like parents' rigid workplaces or older siblings' late school class might reduce the children's interacting time with their parents. You can see in the picture on the right side that 4 circles around the person are the microsystems, and the bigger circle with the not dotted line is the exosystem. In this study, we suppose that mother's work-family gains, which belongs to the exosystem, influence the mother's permissive parenting practice and children's media dependency, which directly interact with children and refer to the microsystems, consequently affect individual children's communication skills. Therefore, we made 2 research questions to verify our hypothesis. First, does mother's work-family gains influence children's communication skills? And second, does mother's work-family gains influence children's communication skills dual mediated by mother's permissive parenting practices and children's media dependency? Next, I'm going to introduce you how this study was proceeded. First of all, this study used the data from the 10th version of the panel study on Korean children, which was processed in 2017. Originally, this panel study surveyed more than 2,000 participants, but this study used the data which was collected from 707 children, consisting of 364 boys and 343 girls, and their mothers, of course. Since the study is about mothers' work family gains, I excluded the data of children without working mothers. The children's mean age was 9.4 years old, and they were all elementary school students. Of 707 working mothers, most of them were full-time workers, and 9.6% of them were temporary workers, and the rest of the working mothers were employers or own account workers. And then we use the following measures to survey about the variables. Among these measures, the former two measures were used after the translation from English into Korean, and the other latter two measures were used without translation since it was first produced in Korean. These measures all collected data from the Korean working mothers' own reports, and among these measures, in children's media dependency measures, the word media refers to computers and smartphones, which children mostly use these days. Then, this study used the highest model 6 to examine the influence of mother's work family gains on children's communication skills and verify the dual mediation effect. Also, descriptive analysis, correlation analysis, regression analysis were conducted with SPSS, and furthermore, bootstrapping was conducted with process macro to verify the dual mediation effect. Next, I'll show you how this data was statistically analyzed. First, mother's work family gains showed significant positive effect on children's communication skills from linear regression analysis, as you can see in the picture. And then I proceeded the regression analysis for the whole dual mediated model by highest model 6. And as you can see, it showed that mother's work family gains negatively influence mother's permissive parenting and children's media dependency, while positively influence children's communication skills. In addition, mother's permissive parenting ne- positively affected children's media dependency, while negatively affected children's communication skills. And then you can see that children's media dependency negatively impacted children's communication skills. In other words, if mother's work family gains increase, it reduces mother's permissive parenting practices, which increase children's media dependency and negatively affect children's communication skills. Accordingly, children's media dependency decreased also decreased following the decreased mother's permissive parenting practices, and consequently, as children's media dependency decreased, the children's communication skills get increased. Also, mother's work family gains showed significant direct positive effect on children's communication skills. But as you can see, as a decreased amount than before we saw in the last slide. It shows that there was a partial mediation effect among this model. Next, I bootstrapped these models through process macro. The bootstrapping process with a 95% confidence interval, and as a result, it showed significant total effect and direct effect. Also, indirect effect in three pathways turned out to be all significant. First, the pathway from mother's work family gains to mother's permissive parenting and children's communication skills showed significant indirect effect. And then, so does the pathway from mother's work family gains to children's media dependency and to children's communication skills also show the significant indirect pathways. And last, the pathway from mother's work family gains through mother's permissive parenting practices and children's media dependency to children's communication skills also show the significant indirect effect as former pathways. In some, the mother's work family gains significantly influence children's communication skills, dual mediated by decreased mother's permissive parenting practices and children's media dependency. However, even if this study acquired significant results, the study still has several limitations. First, the data of this study collected through mother's own reports, so this data may not precisely reflect the children's actual conditions about media usage or communication skills in school. In other words, mothers may not exactly be aware of their children's conditions while they are not under their supervision. So, in in the further study, we should collect data from children's own reports, especially for children's media dependency or how children communicate with other people without their parents' supervision. Second, since this study collected the data from the same period, there are difficulties to verify the longitudinal effect on communication skills. Since the communication skills were developed through accumulated linguistic interactions and experiences, as I presented in the introduction section, uh, the further study should try the longitudinal research about this topic. And lastly, the study only focused on the mother's effect, and this made us only focus on one side of parental effect on children's communication skills and neglect the father's role on children's development. Consequently, it enables incomplete interpretation about this topic. Nowadays, the importance of the father role and the co-parenting of couple in raising children are verified through many existing studies. So, in the further study, we may include how fathers' work-family gains or conflicts or fathers participating in parenting can influence their children's media dependency or communication skills, or how it affects to their wife's work-family gains. However, although this study has several limitations, this study can suggest several implications. First, the study emphasized that the positive influence of working mothers' work family gains. Since most of the existing research focused on how mothers' work family not gains but conflicts negatively affect their own well-being or couple relationship or their children's development. This study will shed a light to the related research and understanding the overall impact of juggling jobs and parenting, including the work-family conflicts and work-family gains together. Also, the study verified the mother's work-family gains can positively affect their school-aged children. Most existing studies about working mothers focus on how it impacts on infant development or the early stages of life. However, the study verifies that working mothers' parenting still has influence on even grown-up school-aged children, who are considered more independent than infants or younger children. In sum, this study provides an academic basis for the importance of supporting working mothers raising school-aged children to make them feel satisfaction from handling various roles, and explains why employers, communities, and societies should try to support these working mothers who are raising school-aged children and shows that this support should not be limited to mothers with infants or young children because this study shows that mothers' work family gains and consequential parenting actually matters to not only to younger children but also to school-aged children. Uh, And this is the end of my presentation. And if you want more detailed information about my article, you may access my article through this code on the left side of this page, or you may browse my article through this APA style references on the right side, or you may send me an email through this corresponding address. And this is the email of my professors, so you can contact with me through this email. I sincerely thank you for your listening. Thank you.
Okay, today I will bring the topic of the role of hyponatremia, or which is low plasma sodium in predicting urinary tract infection severity. And I'm from the Department of Pediatrics of Chime Medical Center from Taiwan. And urinary tract infection is one of the most common bacterial infections in children. It affects about 8.4% of girls and 1.7% of boys before the the age of 7 years old. And there are several peaks of UTI incidence during the infancy for both genders and around the time of toilet training and in the beginning of sexual activities in girls. We can also classify UTI by the location of the infection. It could occur from the urethra to the renal parenchyma. So it's called urethritis, cystitis, or pyelonephritis when the infection further ascends to the kidneys. To differentiate acute pyelonephritis from lower urinary tract infections can be challenging, especially in younger children. And the gold standard for diagnosing acute pyelonephritis is the DMSA scanning. However, its routine use is not generally recommended due to the radiation dose and several practical issues, such as the availability of the test at the hospital. And among patients admitted to the pediatric ward for UTI, it will be helpful to have markers that help us predict the severity of the disease and the likelihood of having acute pyelonephritis. And the following table shows some features that can be helpful in differentiating these two conditions, including age, fever, presence of systemic symptoms or urinary findings, renal bladder ultrasonography. So when I was a resident, one of my teachers told me that he observed that hyponatremia is more common in more severe patients. And I had some question about that, so I looked up for some references. And indeed, it's not a very commonly mentioned association with severity of urinary tract infection. Some of the papers were from the 1990s, and there is also a recent publication over this topic. So hyponatremia is when the plasma sodium is less than 135 millimoles per liter. And today, only a few studies have suggested hyponatremia to be associated with acute pyelonephritis, which or reflects a more severe inflammation in children with febrile UTI. Some of the possible pathophysiology that have been proposed is that maybe the severe inflammation of the kidney will cause transient resistance of the distal tubule to aldosterone, which will lead to hyponatremia and hyperkalemia. Some references suggest that hyponatremia itself may be a substantial inflammatory marker that is significantly and independently associated with the degree of inflammation in febrile UTI children. So the purpose of my study is to test whether hyponatremia is associated with a more severe presentation or acute pyelonephritis in children with UTIs admitted to my hospital. And the following is my method for this study. I performed a retrospective trial review of all the pediatric urinary tract pediatric admission cases with a diagnosis of UTI or acute pyelonephritis from my hospital. And the study period was between September 1st, 2012 to August 31st, 2022. And the following is the exclusion criteria. Okay, we excluded patients with missing data, including renal bladder sonography or blood sodium level, which is the main goal of this study. We also excluded patients with urine analysis or urine culture not meeting the AAP definition for UTI diagnosis. And so the diagnostic criteria for this study was accordingly to the AAP definition, which includes clinical symptoms, urine analysis with evidence of inflammation, or which is pyuria, at least 5 WBC per high power field, and urine culture result of at least 50,000 CFU per cc of a uropathogenic organism. And the diagnostic bacterial count also varies depending on the urine sample collection method. And so we also use the above cutoff values according to the different methods of sample collection. So in the end of all the pediatric patients during the study period, there were 1,748 cases admitted to the hospital. But when we further looked up the urine analysis or urine culture, about 1,100 patients did not fulfill the inclusion criteria. But we also know that sometimes in early UTI, there might not be pyuria yet, or the urine culture may not really yield the CFU cutoff value we set for the study. So our study had a more strict criteria, so that all the cases we collect are all diagnosed according to the AAP criteria. We also excluded 304 patients because they did not have renal echo result or blood sodium testing, which are important variables we want to review in this study. So in the end, we enrolled 344 cases into our study, and according to the plasma sodium level, these 344 patients were separated into two groups, the hyponatremic group with 99 patients and the non-hyponatremic group with the rest, 245 patients. So the following is the data distribution, and we have the hyponatremic group on the right side and the non-hyponatremic group on the left side. So we can see that between the two groups, there was no significant difference between the age or the sex. And the median age of our study population is around 0.3 to 0.4 years of age, which is around 4 months old. So mainly the study participants were young infants. And according to the severity or echo findings, we noted that the hyponatremic group had a higher proportion of acute pyelonephritis. And the hyponatremic group also had a higher proportion of abnormal renal echo findings and a higher proportion of nephromegaly under renal sonography. And there was no significant difference between VCUG findings or hydronephrosis. We also noted that in between the two groups, the duration of stay in the hospital was very similar. There was no significant difference in the admission days. As for the blood testing, we noted that the hyponatremic group had a slight lower HB, a significantly higher CRP level, and a higher blood glucose level. And a proposed mechanism was that there might be some aldosterone resistance during severe UTI. However, we did not note the hyperkalemia finding proposed by the previous studies. And in the urine analysis, we noted that in between the two groups, the only significant different variable was pH, and only just slightly lower in the hyponatremic group. We also look at the most common pathogen in the two groups, and both groups had a very high proportion of E. coli, which is the most common pathogen in pediatric UTI, followed by Klebsiella pneumonia and Proteus mirabilis. We also performed the multivariable analysis for the above variables. And so in the univariable analysis, we noted that hyponatremia was associated with positively associated with APN diagnosis, associated with abnormal renal echo findings, associated with nephromegaly and higher CRP level and glucose level, while it is negatively associated with pH value in the urine. However, after multivariable adjustment, the adjusted odds ratio was only significant for CRP level and glucose. However, the adjusted odds ratio is very near to 1, so maybe it's not that clinically significant, though it's statistically significant. For discussion, we have reviewed past papers, and they suggest that hyponatremia in hospitalized children correlates with elevated inflammatory markers and a more severe disease course. And some papers suggest that hyponatremia may be a substantial inflammatory marker, significantly and independently associated with the degree of inflammation in children with febrile UTI. So in the 2021 study by Papo et al., they enrolled 219 patients, and the median age is also like our study, young infants, 5.5 months of age, and about 49% of their participations had hyponatremia. And they noted that hyponatremic patients had a longer hospital stay and abnormal findings on renal ultrasound and a higher CRP level. So our result is consistent with the bottom two, but we didn't note a longer hospital stay in our study. And also in the past literature, hyponatremia and hyperkalemia also are observed in young infants with severe acute pyelonephritis. And this was explained as a result of resistance of the distal tubule to aldosterone. However, in our study, we did not see that there was any significant difference between the two groups over serum potassium level. There are some limitations to our study, though. Most of the patients were young infants. We initially wanted to perform the study in all age groups of the pediatric population. However, this is because babies are more difficult to draw their blood. So the babies routinely receive blood sampling after admission at our ward, and we routinely perform blood sodium level at when we perform the blood sampling at ward. However, because most older children and teenagers receive blood samples at ER, and so those admitted through the ER did not have blood sodium level, which is the main variable we want to look at in this study. And also maybe because most of the older children or teenagers don't necessarily need to be admitted for UTI. So this can explain why our study enrolled mostly young infants around the 4-month-old period, similar to previous studies. And we also had limited data because it is a retrospective study. Okay, we only had plasma sodium, plasma potassium level, and urine-specific gradient and variables that can be obtained through urine analysis. We don't have further data over blood osmolarity, the patient's volume status, or urine biochemistry results. And we know that when approaching a patient with hyponatremia, we should also note the plasmolarity. Maybe it's pseudo hyponatremia. Okay, we had included blood glucose level, so it's maybe it's not due to this reason, but also we can use the volume status and plasmolarity to further identify the different etiologies of hyponatremia. For example, such as in this case, SIADH and so cerebral soul wasting syndrome, we can use these variables to further help us differentiate between these conditions. So back to our limitations, if we could have further information over blood osmolarity, volume status, or further urine biochemistry, maybe we can further identify the different etiologies of hyponatremia. So in conclusion, in our study, by the univariable analysis, we noted hyponatremia to be associated with increased APN diagnosis, renal echo anomaly, and CRP level. After multivariable analysis, we only noted hyponatremia to be independently associated with increased CRP level, though the odds ratio is around 1.0, so we have to take this into consideration. And further studies addressing the different etiologies of hyponatremia may further help us elucidate the relationship between hyponatremia and UTI disease severity. So the above is my presentation today. Thank you.
Good day. I am Larissa San Jose, Fellow in Training from the Section of Pediatric Gastroenterology, Hepatology, and Nutrition from the University of Santo Tomas Hospital, Philippines, and I present my case, the non-surgical case of acute abdomen in an adolescent male, a case report on epiploic appendicitis. The objectives for this case is to present the case of the 11-year-old boy with left lower quadrant pain, discuss the incidence and pathophysiology of epiploic appendicitis, and to discuss the management of epiploic appendicitis. Our patient is the 11-year-old male from Lucena, Quezon Province, Philippines, with the informant, which is the mother, and the patient with good reliability. He presented at our institution with left lower quadrant pain. History of present illness started 4 days prior to admission when he suddenly felt a left lower quadrant continuous pain, piercing, and localized, graded 7 to 10 out of 10, which was aggravated by movement. There were no accompanying symptoms. 2 days prior to admission, he noted that the abdominal pain increased, graded 8 to 10 out of 10, localized with no vomiting. He also noted that there was frequent flatus. He was admitted at a hospital in Lucena, Quezon Province with an assessment of acute abdomen. During this admission, the white blood count was 18.3, which was elevated. However, the urinalysis and the whole abdominal ultrasound was unremarkable. A day prior to admission, he still felt pain of 8 out of 10 over 10, and the attending started cefoxitin at 46.8 mg per kilo per day. A repeat complete blood count showed increased WBC of 13.9, and during this time, a whole abdominal CT scan was requested, which showed a 3.3 by 2.1 centimeter fat density ovoid structure adjacent to proximal sigmoid colon showing peripheral fat strandings, a hyperattenuating ring-like structure. No abdominal calcifications noted. The impression during this time was epiploic appendicitis versus omental infarction. The patient was then referred to our institution due to the unavailability of a pediatric surgery referral. Encircled in yellow is the noted lesion of epiploic appendicitis versus omental infarction. The review of systems of our patient was unremarkable. Social history was unremarkable as well. Nutritional history showed that he is able to reach the recommended daily allowance for his age. And past medical showed that he was diagnosed with Hirschsprung's disease in 2014, status post-endorectal pull-through with no complications. He is a known asthmatic with the last attack at 6 years old and is currently on salbutamol as needed. Family history and socioeconomic history were unremarkable as well. Pertinent physical examination showed that he was ambulatory conscious, not in respiratory distress, overnourished, well-hydrated, well-looking, with unremarkable vital signs. Pertinent examination of the abdomen showed that the abdomen was flabby, with no surgical scars, and the tympanitic in all quadrants. But note of grade 1 to 2 out of 10 from the previous 7 to 10 out of 10 tenderness on the left lower quadrant pain on deep palpation. There was no Murphy sign, no obturator sign, no Iliosowa sign, no Robsings, no guarding, and no rebound tenderness. But we note that in diagnostic imaging and abdominal pain, CT is considered a reference standard study for abdominal pain because it has high diagnostic accuracy, with a sensitivity and specificity of 96%. With this, with the 4-day history of sudden continuous left lower quadrant pain, piercing, non-radiating, grade 7 to 10 out of 10 aggravated by movement, which decreased to 1 to 2 out of 10, the patient of having been overweight, and tenderness of 1 to 2 out of 10 on the left lower quadrant on physical examination, and the CT scan finding of epiploic appendigitis versus a mental infarction. We now try to check if what our patient has is either epiploic appendigitis or a mental infarction. Our patient is an 11-year-old male and overweight, diagnosed to have Hirschsprung's disease in 2014. Your epiploic appendigitis, although more common in adults, it is rare in children, with a predominance of gender of male than females and a reported age of between 12 to 18 years old. Risk factors would include those patients who are obese, and some of them would note that the epiploic appendigitis would occur to be exercise-induced, but majority of which are idiopathic of cause. There are only 21 cases reported worldwide since 2000, whereas our mental infarction is usually more seen in patients less than 20 years old. And one of the risk factors would also include your obesity, strenuous activity, and sometimes in those patients with recent abdominal surgery and abdominal trauma. Since 2000, there have been 129 cases reported as well. With our patient's physical examination findings of sudden left lower quadrant pain, initially 7 to 10 out of 10, decreasing to 1 to 2 out of 10, localized and aggravated by movement. In epiploic appendigitis, there is usually non-specific symptoms, and these patients would be usually well-looking. The pain can be acute or localized, and majority of which would occur on the left lower quadrant. And sometimes the epiploic appendigitis would not be aggravated by movement. In a mental infarction, patients may present with nausea, vomiting, anorexia, diarrhea, or fever. However, the pain can be again sudden and localized, but majority of which would present at the right quadrant, either on the right upper quadrant or the right lower quadrant. Some patients may present with or without rebound tenderness. Our patient also presented with leukocytosis with unremarkable ultrasound and urinalysis, with a CT scan finding of the fat density ovoid structure adjacent to the proximal sigmoid colon, showing peripheral fat strandings and hyperattenuating ring-like structure. In patients with epiploic appendigitis, these patients may present with a normal leukocyte count or mild leukocytosis. Some of them may present with mildly increased inflammatory markers. CT scan findings of these patients with epiploic appendigitis would have 2 to 3 centimeters hyperdense rims surrounding ovoid masses, which is called your hyperattenuating ring sign. Fat stranding is more pronounced. There could be central hyperattenuating, ill-defined round areas called your central dot sign. Versus in a mental infarction, sometimes these lesions would appear larger than those of your epiploic appendigitis, usually more than 7 centimeters, and is centered in the omentum. We would also appreciate concentric linear strands, and these findings may still overlap with epiploic appendigitis, and the two entities cannot be fully differentiated. So our admitting impression was acute abdomen secondary to epiploic appendigitis to rule out a mental infarction overweight. On the first hospital day, the patient was seen comfortable, conversant with stable vital signs and a febrile with no signs of dehydration. The abdominal tenderness was noted to be 1 to 2 out of 10 on the left lower quadrant. He had no vomiting, no abdominal enlargement, and had frequent flatus. Until cleared from the service of surgery, we kept the patient on nothing per RM, and HGT was also monitored. The repeat CBC was 13.6 from 12.1 with an elevated CRP of 18.5. Patient was started on omeprazole, cefoxitin was continued, and the referral to pediatric surgery. Their assessment was epiploic appendigitis, and the patient was only for serial abdominal examination. We repeated the complete workup, and then CT scan was also requested.
Good day, doctors. I'm Timothy Villanueva, first-year radiology resident, and I will present to you the triple-phase contrast CT scan of the whole abdomen of patient RCA 11-year-old male. A non-enhancing ovoid structure with attenuation value similar to fat is noted in the anterior aspect of the proximal sigmoid colon. The surrounding fat strandings are noted within the left lower quadrant, likely representing an infectious or inflammatory process. A small hyperdense focus is appreciated within the lesion, as pointed by the yellow arrow. This may represent a thrombus vascular pedicle. The adjacent segment of the sigmoid colon appears normal with no apparent wall thickening. Radiologic impression is considered an infectious or inflammatory process, such as epiploic appendigitis in the proximal sigmoid colon as described. Thank you.
Thank you, Dr. Tim. So again, on the third hospital day, our patient was symptomatic with good activity and appetite and was on full diet. The patient was eventually discharged and the cefoxitin was shifted to cefuroxime to complete 7 days and dietary advice was given. Our final diagnosis was epiploic appendigitis, overweight. Epiploic appendigitis is an inflammation of the epiploic appendage and a rare cause of abdominal pain that often manifests with acute onset of abdominal pain, either on the left or the right lower quadrant. We note that these structures are between 1 to 2 centimeters thick, 0.5 to 5 centimeters long. The size and number increase in the lower abdominal quadrants, 57% of which are found in the rectosigmoid junction and 26% in the ileocecal region. It is theorized that the fat projections act as cushions providing mechanical protection or as storage of blood supply during peristalsis. Their pathophysiology have been either due to the torsion of an appendage or the spontaneous thrombosis of a central draining vein, of which both conditions would present with edema, ischemic necrosis, aseptic inflammation. The gradual torsion of the appendages can result with chronic inflammation with or without symptoms, and by contrast, the acute torsion is associated with the immediate development of symptoms. Epiploic appendigitis could either be primary, which is an acute ischemic inflammation resulting from the torsion of an appendage or spontaneous thrombosis of a central draining vein, and secondary, wherein the epiploic appendage is inflamed because of another process, such as diverticulitis, appendicitis, pancreatitis, or cholecystitis. It occurs in 8.8 million per year and may occur at any age, usually found to the 2nd to the 5th decade of life, and men are more affected than women, and associated with obesity, hernia, and exercise injury. Case reports have been published, wherein from 2000 to 2018, there have been 21 reported cases among the pediatric population, of which more to be seen in the males and the median age of 8 years old. The abdominal pain for patients with epiploic appendigitis are usually acute in onset, left more than the right, with or without rebound tenderness. Patients would present with no rigidity and is localized and not aggravated by movement. Fever, nausea, vomiting, diarrhea, and constipation are sometimes present but usually absent. In case reports, these patients among pediatrics, right lower quadrant is more commonly seen in some patients, and anorexia and nausea can also be present. The laboratory findings for epiploic appendigitis can be seen as follows. Our white blood count cells may be slightly elevated. Our anti-inflammatory markers are usually normal but may mildly elevated. Some request for liver transaminases, pancreatic amylase, lipase, and urinalysis, which are all normal. Diagnostic imaging with regards to the diagnosis of this disease, we may do the CT scan, the ultrasound, or the MRI, and the CT scan is usually the first imaging of choice. It is accurate, non-invasive, and the non-contrast enhanced is already sufficient. So the CT scan findings of this disease are usually our solitary ovoid lesion, the hyperattenuating ring sign, the thickening of the parietal peritoneum, fat stranding, and central dot sign. The fat density lesion would usually measure at 1 to 5 centimeters in actual diameter, abuts the anterior large wall. Your hyperattenuating sign usually indicates compression of the inflamed visceral peritoneum. The thickening of the parietal peritoneum indicates the spread of inflammation. Fat stranding is usually seen due to the segmental asymmetric thickening of the adjacent colonic wall, and the central dot sign is highly indicative of the central venous pedicle thrombosis with the inflamed appendage. Again, with the differential diagnosis of a mental infarction, the hyperattenuated rim and the central area of high attenuation is not seen in a mental infarction. The anatomic location relative to the common of the omental infarction is usually centered in the omentum, and the pain would usually be in the right lower quadrant or right upper quadrant. Management-wise, that once the diagnosis is confirmed with the clinical and imaging findings and other diagnoses are excluded, conservative management would ensue with your analgesics with or without NSAIDs. However, with the persistence of the abdominal pain, if it is a recurrent primary epiploic appendiditis, we may resort to laparoscopic excision of the inflamed appendage. If these patients would usually present with pain, NSAIDs is the first choice of treatment, and antibiotics can be given, but their therapeutic benefit is not established. Usually, these patients would show resolution of symptoms within 1 to 2 weeks, and the symptoms would be lessened by 4 to 5 days. Like if the conservative approach fails to alleviate symptomatology, laparoscopic excision of the affected appendage may be required. Again, for the diagnosis, in some literature, they note that these patients underwent surgery and located the epiploic appendiditis. Majority of which of these patients showed that the epiploic appendiditis was noted at the cecal area. Again, for the diagnosis, some case reports published note that preoperatively, they were able to see this epiploic appendiditis at CT scan. 12 patients out of the 13 actually underwent conservative management, while the other patients underwent 13 surgical procedures. 4 of which of the 8 were diagnosed to have epiploic appendage, and 3 had acute appendicitis. So prognosis-wise, complications, although rare, there could be abscess formation, there could be obstruction, intussusception. High recurrence rate was noted to be present in patients with NSAIDs only, and with regards to monitoring, the findings would usually resolve within 6 months after the onset with either size reduction or complete regression. In chronically infarcted epiploic appendage, they may develop a septic fat necrosis, gradually transforming into a fibrotic or calcified nodule. And if invasive intervention is usually avoided due to the potential complications present in all surgical procedures. So my conclusion is that initial goal in the evaluation of acute abdomen is to differentiate surgical and non-surgical conditions. Management should be a team effort involving the pediatrician, a surgeon, and a radiologist. Epiploic appendiditis is a rare and frequently misdiagnosed case of acute abdominal pain in patients presenting at the emergency department. CT is a diagnostic imaging modality of choice, and its usage has resulted in increased recognition and diagnosis of primary epiploic appendiditis. Radiologic findings of the ovoid solitary lesion, a hyperattenuating ring sign, a central dot sign are the pathognomonic findings in epiploic appendiditis. Epiploic appendiditis is managed conservatively. Thank you.
Respected audience, I would like to welcome you all to my presentation on the transcatheter closure of ventricular septal defect from retrograde approach. So the thing I am discussing now is a disease of the heart, which is ventricular septal defect. And you are seeing here that this is the ventricular septum, and there is a defect here, and blood is leaking from the left side of the heart to the right side through this defect. So this is the impression about the ventricular septal defect. It constitutes about 20 to 30.
Just a second. I would like you to put it in full screen, the presentation mode. Yeah. Sorry.
Oh, sorry, sorry. I thought it was full screen.
Yes.
So it's good now? Yeah.
Yes.
So BSD, it constituted about 20 to 30% of all the congenital heart defects, and it is a cause of significant morbidity and mortality to the children. And about 1.3 to 3.5 per thousand live births are suffering from this condition. And with the advent of the echocardiography, the recognition of the disease is now little bit early, and up to 50 per thousand live births are diagnosed nowadays because of the advent of investigation tools. Spontaneous closure of the small defects occurred before the age of 3 years in many of the children, and patients with significant hemodynamic effects or small defects with complication, they need closure in subsequent days. Surgical closure is the gold standard and established procedure for the closure so far, but percutaneous device closure through the transcatheter techniques was first reported in 1988 by Locke et al. And device closure of BSD was started in my country, Bangladesh, since 2004, which was first done in Combined Military Hospital, Dhaka. Percutaneous closure is a recent technology which offers less aggressive, minimally invasive, and more comfortable alternative of the BSD closure, and it is acceptable to the physicians as well as to the parents of the patient. Along with the surgical closure, transcatheter device closure of BSD through retrograde approach by forming arterial loop is an established technique, and this is performed usually through the femoral vein and femoral artery. But the approach which I am discussing is little bit different from the classical one. The classical approach is little bit cumbersome and time consuming, and it needs multiple steps and expensive accessories throughout the procedure, which is little bit difficult for the developing country like Bangladesh. Forming an arteriovenous loop by crossing the BSD is technically also a challenging one, and it takes some time, and radiation hazard is also a factor. Fluoroscopy cannot provide landmark over the BSD, so it depends on the expertise and skill of the operating cardiologist. So these are the locations you are seeing here, that this is a ventricular septum, which is a vast area, and BSD may be located in any place like perimembranous to muscular, and muscular may be in the apex or in any other place. So these are the locations of the BSD, and according to echocardiography, we can see that the location of the BSD is as above. So this one, yellow one is a perimembranous BSD. This one, pink one is the muscular BSD. So according to echocardiography, we can identify them like this. And anatomically, sometimes we can say that above the crista terminalis is the supracrystal type of BSD. And in the muscle, it may be anterior muscular, posterior muscular, apical muscular. It may be near the inlet, like near the tricuspid valve, so it is inlet BSD. And perimembranous is around the perimembranous septal region. So what are the types of BSDs which are suitable for device closure? Perimembranous BSD is one of the type, which is here, and then muscular BSD, which is located usually in this location. These are suitable for device closure, but some of the subarterial BSD, subaortic BSD, and doubly committed BSD, they are also suitable for device closure in some cases, some selected cases, not in all cases. So what are the types of the devices which we usually use for doing device closure? These are mainly muscular BSD occlusion, amplifier duct occluder 1 and 2, PM BSD occluder, then PFM BSD coil, hook coil, clamshell device, and recently we are using lot of multiple occluder of corner for closing the BSDs. So these are the actually photographs of the devices. This is a classical PM device. This is a muscular BSD device, and this is the MFO, which is a very good one for closing BSD, like perimembranous one. So one of the devices is AD1. Its design is like this, and its strength is it needs smaller excess material through the femoral vein, and then it is less expensive, and complete heart block is rare with this type of device, because complete heart block is a very common complications in case of the device closure, and some of the devices are very stiff and they are more prone to cause complete heart block. Now, choosing the devices, we can go by echo, by doing echo, or by angiography. We can see the size and type of the BSD, and then we can choose the device. Now, minimum diameter of the defect on the RB side plus 2 millimeter is usually selected for closure of the VSDs. Now, ADO1 has some limitations also. What are these limitations? One of the limitation is it is not designed for the perimembranous VSD, and then separation from the aortic valve is also a matter. So 4 to 5 millimeter distance is required because of the long left ventricular side of the disc. And aortic retention disc sometimes enters the aortic valve if the distance is less. And there is some interference with the tricuspid valve mechanism as well. So this device is not good for all the cases, but it is good for some cases like with the aneurysmal tissue. Now, ADO2 is another type of the device which is here. And what are the advantages? It is a softer kind of device. It has wider waist. Complete heart block is rare in this case, and there is ease of deployment in this kind because there is 2 screws on 2 sides. So we can go through both arterial and venous approach with the same device. And there is some limitations also with this ADO2. So it is not designed for the PMBSD. So it is not a classical device for the BSD, but we do the off-label use of this device. This is specially made for the patent ductus arteriosus. So sometimes there is chance of impairment of the tricuspid valve mechanism. There is chance of encroachment of the LVOT, and it is sometimes it is able to close the VSD up to even 5.5 millimeter. Now, MFO is another device, multifunctional occluder. Its advantage is it offers a vast majority of options, like we can go through antegrade approach, retrograde approach, and even through the foramen ovale, we can use this device. Larger devices are available, which is a very big advantage for closing larger size holes also. And size of the delivery system of this device is very small, and it can be deployed through guide catheter. So it is good for using in neonates or in young infants. And complete heart block not yet reported with this type of devices. So this is one of the device which is known as multifunctional. This is the game maker because after innovation of this device, we have included many cases in the list of device closure which were earlier excluded for the less body weight, for closer proximity to the aortic valves and others. But now we are taking these cases and closing successfully with this device. So what are the equipments we require for doing the BSD device closure? We need an appropriate occluded device and delivery system for taking this to the proper location, then Terumo exchange wire, arterial and venous sheaths for entry into the vessel, then Judkins catheter, snare catheter, pictal catheter, and exchange wire to exchange with the delivery system. So the diameter of the device selected should be 2 millimeter or 3 millimeter larger than that of the defect measured by LV angiography or by the echocardiography. And for the subaortic VSD, arteriovenous loop is formed from the right jugular venous approach through the right femoral artery when AD1 and a few MFO devices. So for the subaortic VSD, jugular venous approach is used, but for the other, which are in the muscular part or perimembranous, mostly we use in retrograde approach, we use femoral artery for that. And for the MFO and ADO2 devices, no loop formation, and directly we can go through the femoral artery. So this is the photographs you are seeing here is a muscular VSD. So muscular VSD, we are doing it in the retrograde approach, and this is the catheter from the aorta to the LV in retrograde approach. And for the understanding of the audience, I'm showing you here an animation film. You are seeing here that this is the ventricular septum, and the hole was there, which is known as VSD, and now we are closing with the device. So technology is though difficult, but the theme and idea is very simple. So this is the closed BSD with the device. Now coming to the study duration was almost 10 years. It was April 2014 to April 2024, and it was performed in 2 hospitals, Labit Cardiac Hospital and Bangladesh Specialized Hospital, and total 294 patients were selected for this study. It was a retrospective study, and all the records were taken from the computerized records and also from the OPD, eco department, and also from the cath lab department. And follow-up was planned in these cases for 1 month, 12 months, 3 year, 5 year, and 10 years. So some of our patient already has completed 10 years follow-up, where we can share you with our long-term follow-up. Now, if we see the demography of the patient, age of the patients are 5.9 plus minus 4.6 years, and age range from 10 months to 35 years. Some of the patients are very young with a large BSDs with bidirectional sound, severe pulmonary hypertension, and with MFO, we are taking these very young infants also, as they can turn into the Eisenmenger very early. So we are doing them very early with the MFO device. Weight of the patient varies from 17.9 plus minus 8, and 8 kg was the minimum weight, and maximum was 49 kilogram. Female 146 and male 148. So ratio was 1.01 to 1, and male outnumbered female. There were some associated defects with the VSDs. These are ASD, pulmonary stenosis, PDA, BSD. So these are the association of other congenital heart defects with this one. So next, this is the elaboration of the data, which I already have mentioned earlier. And this is the associated disease, which I have mentioned also. So you can see that ASD is the commonest disease, which is associated with the VSD, followed by pulmonary stenosis, patent ductus arteriosus, ventricular septal defect in other locations, not only in the perimembranous, but also there are multiple VSD sometimes in other locations. And sometimes there is association of trivial air or mild air. And symptom-wise, these patients reported to us with some of the symptoms, and mostly they were referred to us by the pediatrician. So why they referred to us? Either they found the murmur or for the symptoms. So the most common symptom to the patients are repeated cough and cold, which is about 85% of the patient, and feeding difficulty with suck post-suck cycle to the young infant was in 38% patient, and then not growing well, failure to thrive in 38% patient. In 43% there was recurrent pneumonia, and 13% patients were totally asymptomatic but incidental finding of murmur was the reason for referral. And then now we can see what were the type of the VSD we dealt with. Perimembranous VSD was the most common, 206, then muscular, doubly committed subaortic VSD, fenestrated VSD, perimembranous with aneurysmal tissue was a common one in 8%, and postoperative VSD was in 2% cases. There was residual VSD after operation, and we closed them with the devices. Now this is the types of the VSD again in the pie chart. So you can see that green part is perimembranous VSD, and from the literature we can see that 80% of the VSDs are perimembranous VSD. Now about the type of the devices, initially the MFO corner occluder was not available before 2018. So since 2011 we were using duct occluder. So number of the duct occluder is more in case of the perimembranous VSD. So in 150 cases, 58 cases, we used the duct occluder, which is 55% of the case patient. Nowadays, we are using mainly MF corner, not duct occluder too. So in future days, actually percentage of MF corner will be higher than that of the ADO2. Now 42% we are doing the MF corner, and cooked detachable coil for the small cases, it is about like 6% of the cases. So these are the types of the devices again, and you can see here that duct occluder 2 is the maximum in this pie chart. Now, what is the immediate outcome and the cath lab data? Complete occlusion of the VSD was achieved in 94% cases. Out of 294, immediate complete occlusion was 278. But the 8 cases were postponed because of the encroachment of the aortic valve and for infundibular stenosis. So these 8 cases were postponed, which is 2%. Residual shunt was seen in another 2% of the cases. Neo aortic regurgitation was seen in 4 cases. And procedure time was 31.6 plus minus 13. Fluoroscopy time was 9 plus minus 3. And combined intervention was done in some of the cases, like combined ASD and VSD in 12 cases and PD and VSD in 10 cases. Access site hematoma was observed in only 4 cases, and transient arrhythmia was noticed in 16, which is about 5% of the case. So this is the elaboration of the same table. I'm not going to discuss it here. And now the cases which were postponed, we have mentioned that we have actually 8 cases were postponed because of the encroachment of the valves and infundibular stenosis. So what happened in one of the subaortic VSD, there is encroachment of the valve. In second case, it was a doubly committed. So there was encroachment of the valve. Third case was doubly committed, and there was severe RBOT obstruction, so we cancelled. And number 4 to 8 cases, there were PMVSDs, and all of them had some kind of encroachment of the aortic valve, and mild to severe form of aortic regurgitation developed as a result. So we were actually pushed to take out the device immediately, and we referred the cases to the surgeon later on. So this is the long-term outcome. You are seeing that 1 month, 12 months, 3 years, 5 years. So all the patient has completed their first year follow-up with all 286 cases, but in third year we have so far recorded 248, and fifth year 90 cases, and 10th year completed 50 cases. So if we see what is the complete occlusion rate, 99% in first month, 99% in 12th month, 99.19% in third year, 97.78% in fifth year. As the number of patients is less here, and many of the cases who are still having residual problem, they are the one who came. So the completely cured patient, they are now reluctant actually to come again for the OPD follow-up regularly. So their number is less. That's why percentage of the residual cases are a little bit higher here. And then the 10-year follow-up, all the 50 cases came, they have complete occlusion. So this is a very good one on the 10 years follow-up. No residual shunt in the 10-year follow-up, and right bundle branch block 0, complete heart block, which is a very common problem in other studies. But fortunately, in my study and in my case, we have never experienced any cases of complete heart block because of some of the extra precaution which we always take during doing the procedure. So I will show you 1 or 2 of the interesting case, and then my presentation will be finished. So these are some of the interesting cases. It is a 2-year-old, 10-month-old guy, 8 kilogram body weight and male, and there was like suffering from pneumonia also, lungs crepitations was present. And then we treated for the pneumonia first, and then we took for the device closure. And this is the one VSD you are seeing here, and this one is the echo after device closure. So this is very close to the aortic valve, and we could able to close it. You see that aortic valve is free and there is no aortic regurgitation. So this is from the cath lab. This is the retrograde approach. We are going through the aorta. You are seeing that aorta. We are entering into the left ventricle, and this is the LV graphic showing that there is a small perimembranous VSD here, and this is the procedure of implanting the LV side of the disc, RV side of the disc first. As we are from the retrograde approach, we have to implant RV side first, followed by the LV. So here in this third one, you can see that we have finished in the both side deployment, and it is now this is the scenario now. Now we are checking the aortic valve, whether there is any encroachment, whether there is any air, no air, so we finish the procedure. And this is another case of 2 year and came with the breathing difficulty, and recurrent fever and respiratory infection. So this is also the echocardiography. Say this VHD is little bit large one, and we closed with the device, and this is after the closure. So this is another one, 20 years. So all the patients are not like very young infant. This is a 20-year-old, reluctant to feed and failure to thrive. Weight was like 33 kilogram in 20 years of age. And this is a sub-aortic, not a perimembranous. So it was a difficult type of case. And here you are seeing that this is a sub-aortic location. RB side is little bit smaller in this VHD, but LB side is larger here. So this is the same retrograde approach. We have deployed the left side first, and then right side first, and then the left side. So you can see better here in this video, both sides deployed, and now this device is released from the delivery system, and all is well now. So these are some of the echocardiography and before the device closure, and these are the videos from perimembranous VHD before device closure. So because of the too much video, the presentation hanged. I think this is all about my presentation. There are some videos left, but I think those are not so important. I have already shown what are important, and this is the end of my presentation. Thank you, organizers, for inviting me to this auspicious gathering. And thank you, all the audience, for your patient hearing. Thank you.
Good afternoon once again. At the outset, I extend my gratitude to organizing committee member for giving me this wonderful opportunity. The title for my presentation is Antibiotic Susceptibility of Healthcare-Associated Infections in Pediatric Intensive Care Units and its correlation with the outcome. Myself, Dr. Seema Rai, Associate Professor, Department of Pediatrics, Guru Gobind Singh Medical College, Faridkot, in Punjab, India. Introduction of the study is the healthcare-associated infection can be defined as an infection acquired in an acute care setting which was not present or incubating at the time of admission. With because of the science advancement and all, the first intensive care unit was started in Sweden in 1955, and with the succession, there are lots of changes in the intensive care around the world. With the increasing in the intensive care and use of antibiotics in the various level of healthcare, there is increase in incidence of healthcare infection as well. The India estimates the reported incidence of 11 to 23%, whereas Western pediatric intensive care units report an incidence of 6 to 8%. As per the World Health Organization, the surveillance of antimicrobial resistance should be done at the local, regional, and national level. For this surveillance to be fulfilled, we should know what organism we are growing in our ICU, what is their antibiotic sensitivity and resistance pattern, so that timely intervention can be taken to combat the upcoming very high incidence of pan-drug resistance of bacteria. The most common organism which is usually isolated in hospital-acquired infections are Pseudomonas aeruginosa, Acinetobacter baumannii, Klebsiella pneumoniae, and Staphylococcus aureus and E. coli. So there is a mixture of gram-negative and gram-positive organism. And recently, fungal sepsis also is very high if there is a prolonged stay in ICUs, which is more common in neonatal intensive care unit as compared to pediatric intensive care units. The purpose of the plan, because of this base, the study was planned to know the proportion of various infections, their origin, and their susceptibility, and their effect on the outcome. Outcome in the form of discharge versus mortality were taken, so that we can develop and evaluate strategies to prevent and control healthcare-associated infection in our pediatric intensive care unit. The aims and objectives which we took is, first and foremost, is to evaluate the proportion of various healthcare-associated infection in pediatric intensive care unit. Second was to determine the antibiotic susceptibility of various organisms responsible for healthcare-associated infection. Third was to correlate antibiotic susceptibility of various organisms responsible for healthcare-associated infection with the outcome. Material and method which we use were: the study was conducted in Pediatric Intensive Care Unit in Department of Pediatrics from April 2021 to August 2022. All patients admitted to Pediatric Intensive Care Unit or in emergency ward for at least 48 hours, developing a new complaint pertaining to suspected HEI which was not present or incubating at the time of admission. It means 48 hours after the admission to our ward emergency, a new onset of infection which was not present at the time of admission were taken. The age group was from 1 month to 14 years, and total sample was 102 was taken for the study. The exclusion criteria were: pediatric intensive care unit stay less than 48 hours, patients who were already admitted elsewhere or on any form of antibiotic oral versus IV at the time of admission, or who refused to consent for the participate in the study. Various clinical samples were collected using a standard technique like blood, urine, pus, tracheal aspirate, catheter tip, and body fluids. It will depend what type of hospital-acquired infection we are suspecting. The most common which we took in our study is laboratory-confirmed bacterial infection, urinary tract infection, ventilator-associated pneumonia, skin and subcutaneous tissue infection, vascular access site infections. All the clinical specimens from the pediatric intensive care units patients received in the Department of Microbiology and inoculated on the culture plate: blood agar, McConkey's agar, cysteine lactose electrolyte deficient agar, and incubated at the temperature of 37 to 38 degrees centigrade for 24 to 48 hours, and maximum 7 days cultures were done, and direct microscopy was also done. The antibiotic susceptibility test of various isolates was performed by Kirby-Boyer's disk diffusion method as per clinical and laboratory standard institutes. An infection was considered HEI if all element of Central of Disease Control and National Health Care Safety Network site-specific infection criteria were present, which was within 48 hours of the new onset of infection, after the 48 hours of the hospital admission, 3 days after the discharge, and 30 days within any surgery. The outcome of the patients were recorded as recovered or mortality, and pediatric sequential organ failure assessment score was used to predict the clinical outcome at the time of admission to pediatric intensive care units. The sample size with reference to previous study of healthcare associated infection in pediatric intensive care unit in Ludhiana et al., where a total 1,239 samples were taken. In their study, the proportion of healthcare infections was 13.6%. So prevalence was 0.13% taken. Z is a constant, which was taken as 1.96 with a confidence interval of 95%. And by this formula, in 1.5 years of study, the study population was 200. Since our sample size was more than 10% of the population size which we receive in our pediatric intensive care unit, which is 8 bedded units, was more. So we need this corrected by using finite population correct subscript, and a corrected sample became 102, which were planned to be taken in the study instead of 200, since our hospital data was slightly different from what came out to after calculation as per this statistical method. Now coming to the results of our study. This first bar diagram is a wise distribution of the study population. As we can see, the maximum number of patients were in the age group of 1 to 5 years. And out of which the 45.1% was hospital-acquired infection, and 35.6% were which did not have any HEI. So 23.5 in less than 1 year were HAI, and more than 1 year, more than 5 year, 31.5 were HAI, and the majority of this chunk was non-HAI. So we suspect 384. We took 384 sample, and 4 were excluded based on our exclusion criteria. So finally, 380 subjects were taken, and out of 380, confirmed hospital-acquired infection depending upon the culture's positivity, we took it was 102. So the proportion of hospital-acquired infection in our study was 26.8%. Now coming to presenting complaints of the patient. Majority of the patient which presented to us is from decreased urinary output, which is an indirect measure to for the compensated shock. Rest of the presenting complaints are vomiting, headache, cough, pneumonia, breathing difficulty, dysuria, so on and so forth. This piegram is showing the presenting complaints of various patients which presented to us during the study period. Here this table is showing the antibiotic sensitivity in the hospital-acquired infection. So out of all the HAI, which is a laboratory confirmed bacterial infection, out of this total 63% were antibiotic sensitive and 30% were multi-drug resistant. Multi-drug resistant means with these isolates were resistant to 2 or more drugs. And urinary tract infections were majority, the isolates were antibiotic resistant, 35.7%. Ventilator associated, again the chunk of isolate which were we isolated in the ventilator associated pneumonia samples through ET culture, through blood cultures, all they were, a majority were antibiotic resistance. In the skin infection, sensitivity of was high, 13%, and burn infections were also 2% antibiotic sensitivity, and vexillary excess site infection also, the isolates were having antibiotic sensitivity and no resistance were found in the burn or vascular access site infection. And all this data was statistically significant with a p-value of 0.001. Now coming to this table, which is showing organism associated with different healthcare associated infection. Out of all this chunk, the majority of the patient which grew E. coli in around the culture, the E. coli was 28 isolates and percentage was 27.5%. Then the Acinetobacter baumannii was very high, 12.7%. Then Klebsiella pneumoniae, 12.7%, Pseudomonas aeruginosa, 11.8. MR cones, MRSA were 10.8 and 7.8% respectively. So in our PICU, whenever HAI we suspect, so we now think to start antibiotic depending upon these organisms, which we isolated. The rarest isolate was Burgdorferi cepaceae. 3 patients grew this, and MS cons 9, so on and so forth. So I will not stress into these. I would like to highlight that E. coli was the most common organism, then Klebsiella, Pseudomonas, and Acinetobacter in the list of HAI. I apologize for this busy slide. This slide is showing association of antibiotic susceptibility with different organisms. This Acinetobacter was sensitive 15.2 and 10.7 was resistance. Our most common organism was E. coli. So for the E. coli, the majority of the isolates were antibiotic resistance. 41.1 patient who grew E. coli had antibiotic resistance. Then Acinetobacter, the sensitivity, I would not say very high, but multi-drug resistance were low as compared to E. coli. Then Klebsiella has high multi-drug resistance, 17.9% were antibiotic resistance. Pseudomonas aeruginosa sensitivity pattern was more high. In MR cones, the sensitivity was high. And these differences, antibiotic sensitivity and multi-drug resistance were against statistically significant, as p-value is 0.005. Again, a very busy slide, so I would highlight only the main organism and main antibiotic. This is antibioticogram of all the organism, which all the antibiotic which we do sensitivity in our micro lab. So the major inoculates which grew E. coli. The maximum sensitivity was colistin. And the no sensitivity was against any this the antibiotic which are inherently active against the gram-positive organism like linezolid, vancomycin, cotrimoxazole, and clindamycin. And second, Acinetobacter, if we take again, it is 100% sensitive to colistin, and it is again not sensitive to the antibiotics which is in the down the line, and the resistance to third generation cephalosporin like ceftriaxone and cefotaxime is high. For Pseudomonas aeruginosa, again, the sensitivity is maximum with the colistin, then comes the meropenem, and then piperacillin. The previously used antibiotic like third generation cephalosporin in the form of cefotaxime, ceftriaxone, now is showing the very high resistance again for the hospital-acquired infection. Coming to gram-positive organism, MR cons is because inherently it's sensitive to vanco, linezolid, and clindamycin. So our MR cons, MSSA, MRSA, they all these are sensitive to vancomycin, linezolid, and clindamycin. So if we compare the sensitivity with the linezolid, vanco, cotrimoxazole, clindamycin, so maximum sensitivity is with the linezolid. All MR cons, MRSA, and MSSA, all these are 100% sensitive to linezolid antibiotic. Coming to the resistance of various antibiotic against the different organism. So resistance is very high with the cefotaxime, ceftriaxone. Our favorite antibiotic which we discussed, resistance pattern as we can see is low. For the E. coli, it is 0%. For the Acinetobacter, again it is 0%. For the Pseudomonas aeruginosa, some growth were resistant to colistin. If we take piperacillin, tazobactam combination, it is very high resistance to E. coli. So E. coli were resistant to piperacillin, and again Klebsiella also, and Acinetobacter. So after doing this study, we learned that if we keep on using this in that time, after doing this study, we changed the antibiotic policy. Now piperacillin now we use at the second not initially when we suspect, we start meropenem instead of piperacillin. In that, when we were doing this study, we used to use this. So after doing this study, our choice of antibiotic for HI were changed. So this is the idea of doing such studies so that we can get the data of local organism which are antibiotic sensitivity or resistant. Depending upon these guidelines, we can make the protocol which antibiotic to use when. Now coming on the MRSA, MR cons, and MMSA, they were the resistance to vancomycin were by methicillin resistance Staph aureus. By linezolid, again, no, this gram-positive organism was resistance. Now the outcome of the study population, outcome which we took, discharge versus death in hospital-acquired infection. 81.4% patients were discharged and 18.6% patient were died. And in known HI, 92.1% patient discharged and the mortality was 7.9%. And this result again is statistically significant. Coming to the discussion part of my study, among the 380 patients which we took, 102 patients were having hospital-acquired infection. So overall proportion of hospital-acquired infection in our study was 26.8, and maximum HAI was from laboratory-confirmed bloodstream infection, which was around 45.1%. Now coming to most common pathogen, which was E. coli. E. coli grew 27.5%, Klebsiella pneumoniae 12.7%, and Pseudomonas 11.8%. And these results were comparable to studies done by Fogila E. et al., Berolet and Chaudhary et al. And HCS et al. Has same profile of hospital-acquired infection. Out of E. coli, it is, as already discussed in the result, 100% sensitive to colistin, and 63% to meropenem, 64.3% for nitrofurantoin, and 60% sensitive to imipenem. E. coli showed 100% resistance to cefotaxime, ceftriaxone, and resistance to ciprofloxacin was 82.6%. Same were the results by Berolia PK reported sensitivity to carbapenem around 50%. The mean length of stay was longer among the antibiotic susceptible HAI than the antibiotic resistant HAI with a p-value of 0.031%. This was in contrast to the study conducted by Fuglia E et al., where the length of stay was more among antibiotic resistance. The shorter length of stay in antibiotic resistance HAI could be due to the fact that the death rate was high in the resistant patient compared to susceptible population. So 96% versus 17.4%. The mean pediatric sequential organ failure assessment score was slightly higher in antibiotic sensitivity HAI than the antibiotic resistance, though the p-value was not significant. So laboratory confirmed bacterial infection was the most common HAI. Out of this laboratory confirmed bacterial infection, the most common isolate, which is our conventional study, showed that the most conventional is the gram-negative bacilli, but in our population, in our samples, the most common organism were methicillin-resistant Staph aureus, and followed by MS cons, which is 19.6, and then MR cons that was 17.4%. And the Acinetobacter was 15.2%. This was already shown in the table. And these results were at par with the Chaudhary, which has the Staph aureus with 45%. The second most common HAI was UTI. In UTI, as we always feel that UTI will grow gram-negative organism, so E. coli group was 83.3, followed by Klebsiella. And these results also is in concordance with the Chaudhary J et al., and E. coli was the most common organism. Berolia and another study also had E. coli in their growth in the other UTIs. And the third most common HAI was ventilated associated pneumonia. In that Klebsiella grew, which is being the most common isolate, followed by Pseudomonas, Acinetobacter, and E. coli. Chaudhary et al., Berolia PK also reported the same organism for ventilator associated pneumonia. The mortality was higher among hospital-acquired infection. It was 18.6% than those without hospital-acquired infection, 7.9%. And this value was significant. Mortality among the antibiotic resistance was also found to be become more than the antibiotic sensitivity, which was similar to study conducted by this Fogili et al. The difference in the sensitivity pattern of different center may be due to different antibiotic protocols and emergence of resistance of different state and the different timelines. To conclude, the study reported that proportion of healthcare-associated infection in our PICU was higher than those studies done in India and other countries. The finding of our study highlight the urgent need for effective strategies to prevent and control spread of these infections within the healthcare facility. The strategy should include increased awareness, training for healthcare worker on infection control measure, implementation of strict hygiene protocol, appropriate use of antibiotic, and development of a new effective antibiotic strategies to combat antibiotic resistant strains of bacteria. The strength of our study was we conducted antibiotic sensitivity and resistance of all culture sources in the pediatric intensive care units. It is a very strong move towards the antibiotic stewardship. Such type of data help in deciding antibiotic choices depending upon the local microbiota. The limitation of the study was that we did not take the patient follow-up, as that few places it was written that within 3 days after the discharge or 30 days after the surgery, also if a new infection come, that also should come into this. We just stick to the any new infection which came 48 hours after the hospital admission or coming to the pediatric intensive care unit. And the sample size is considered less to make guideline for the region, as it is a single center study. Maybe multi-center studies will give us more data, and inclusion of NICU and geriatric also will give us data to make antibiotic policy for the full hospital. These were the references which I used. Thank you for patient listening.
So, a very good afternoon to one and all. I would like to start by expressing a heartfelt gratitude to the organizing committee for giving me this opportunity. I am Dr. Dhanashree Dalal. I have completed my MDS. I am pursuing PhD, assistant professor at DY Patil, Dr. DY Patil Dental College and Hospital, Pune. So, without wasting much of a time, the topic today I'm going to be speaking on is that every child counts, tailored dental care for children with special healthcare needs. Uh, upon completion, what attendees will be able to learn is understanding special healthcare needs, identifying oral health challenges, adapting dental care techniques, recommendations pertaining to dental clinic, as well as home care techniques, implementing preventive measures. Now, I'll be emphasizing a lot on preventive measures because I want to focus mostly on how can we prevent a dental disease rather than taking to an advanced stage where it becomes invasive. Navigating barriers, we would be discussing what barriers we are facing and how we can navigate it for patients with special healthcare needs to oral care, and policies on children with special healthcare needs. So, a survey by National Survey of Children Health had done a survey around 2016 to 2018 where they noted that oral health, that is the dental health, is the most unmet need for children with special healthcare needs. So this perhaps stays as the gray area, one of the gray areas in the field of pediatric dentistry, providing both primary and comprehensive preventive and therapeutic oral health care to individuals with special healthcare needs is an integral part of pediatric dentistry. Now, healthcare for individuals with special needs requires specialized knowledge. I say it as 4 A's, that is awareness, attention, adaptation, and accommodative measures, which is beyond the routine. So what comes under the category of a person with special healthcare needs is persons that are considered to have special healthcare need if they have a physical pertaining to handicapped or inability to walk, developmental, a child with cerebral palsy, an example, mental, sensory, behavioral like autism and ADHD, cognitive as an intellectual disability or emotional impairment, or limiting condition that requires medical management, healthcare intervention, and or use of specialized services or programs. So this is the umbrella term in which all of this nature of special healthcare needs resides. So we do not use the term handicapped according to recommended guidelines by Language and Terminology Committee. We use otherwise abled, differentially abled, medically challenged, or which is trending now is special child. So whenever you're referring to a person's disability, try to use person first followed by disability. We can take an example here. Example, a person, a man with autism can be a better example rather than an autistic man. So, what are the concerns that can be seen in oral routine for the child regarding the anomalies or dental findings that can be found in special healthcare needs children is build-up of calculus, which results in increased gingivitis and risk of periodontal diseases, enamel hypoplasia, dental caries, crowding, malocclusion, anomalies in tooth development, size, shape, eruption, and arch formation, bruxism and wear facets, fracture of teeth, or trauma. So there are recommendations that are given by AAPD. According to American Academy of Pediatric Dentistry, revised guidelines in 2023 says for the children with special healthcare needs that they should be having an established dental home at an early stage. We look forward to one by one, obtaining thorough medical and dental patient history, since the children with special healthcare needs need a multidisciplinary disciplinary approach. So there should be no miscommunication with the other practitioners as well. Creating an environment conducive for child to receive care. For example, SAID, which we will be looking into our further slides, and providing comprehensive oral health education and anticipatory guidance. The first concept is dental home. So what is dental home? It's an ongoing relationship between the patient and the caregiver in all aspects of the oral health, regarding oral health, and it should be established no more later than 12 months of age. What does it help with? To implement individualized preventive oral health practices, help establish routine dental care. It reduces the child's risk of preventable dental or oral diseases. The other thing important is scheduling of appointments. Now, the appointments need to be scheduled as per the child's routine. Sometimes early appointment works or late evenings, depending upon the child's the most supporting time, whether his or her sleep is completed. Everything taken into accounts, we can schedule the appointments for this particular child. We have to make sure that there is no other child in the waiting area when we are treating with the child, with this child. So along with the demographic details, you need to note the presence and the nature of special healthcare need the child is having. Secondly, consideration for length of time of the appointment or need for introductory visits helps to ensure a positive experience overall. So the third thing is, in this concern, dentists should provide coordinate care via consultation with patients, other care providers, as we discussed. Physician should be consulted regarding medications, sedation, general anesthesia, and special restrictions or preparations that may be required. Multidisciplinary approach may be necessary in complex case management. Informed consent is a must. All patients must be able to provide signed informed consent for dental treatment or have someone present, for example, guardians or the caregivers or parents who legally can provide this service for them. Informed consent should be well documented in the dental record for the lifetime. Now, behavior guidance. So, there are many behavior management techniques that can be taken into consideration. We'll be talking some of them. The first one is tell, show, do, in which whenever the child enters the operatory, he is told what is going to be done in his language and shown how it is going to be done, and then finally it is done. Desensitization is taking away one's patient sensitivity to any anxiety evoking stimuli. Protective stabilization. Now, this is the second last resort which we'll be taking. It is used only when necessary. Least restrictive alternative should be chosen. It should not be used as a punishment. It should not cause any physical injury to patient. At the end, we need to remember that we are using this protective stabilization technique while doing any kind of dental treatment for the child's betterment during the dental visit. Other ones that are of utmost importance in special child is applying a firm wrap, pressure, and or touch on emotionally disturbed or oversensitive persons. This actually provides a very positive, calming, and comforting effect. And deep touch has a soothing effect on them, where light pat can be a tonic to the nervous system. Now, this doesn't apply to all the cases of the special healthcare children. It is pertaining to some part, for example, in cases of Down syndrome. This behavior management technique works beautifully on them. Now, I've put some pictures just to explain what is the how can we actually get a positive response from the child during the dental visit. One is by Mayer, Johnson et al. Text is picture exchange communication system, in which rather talking verbally to the child, what we want to communicate is given via pictures that can be easily perceived by the child without any miscommunication or gaps. The another one is SAID, which we were supposed to see, that is sensory adapted dental environment. It has been used in cases of a child with autism, and has worked for them. This is pre-appointment mailing, in which you can minimize the anxiety of a child that is visiting the dental clinic by providing some or the other kind of visionary or visual visual pictures or videos, which is actually going to depict on how the treatment is going to be carried on in the dental clinic, as well as can tell them what is going to happen right from the start till the end of the dental treatment. That will minimize their anxiety levels to a bare minimum. Now we move on towards the preventive strategies. Now in preventive strategies, the most important point here is brushing with fluoridated dentifrice and toothbrush. Somehow fluoride is a very underused intervention. It has proven to be the most essential aid in preventing dental caries and has to be promoted by the dentist. The second point is non-cariogenic diet. The child's parents or caregivers or the guardian should be educated regarding the diet and how sugar-free liquid medicine will be keeping the dental decay at bay. So this has to be shared. This education or the counseling has to be given to each and every guardian or caregivers or parents of children with special healthcare needs. Now, this chlorhexidine mouthwashes, can be helpful in minimizing the severity of dental plaque and gingivitis at bare minimum in such cases. So it has to be used. Topical fluoride, the topical fluoride and sealants has to be done with the dentist coming into the picture. And it has to be done routinely as your dentist suggests, and it should be a routine that has to be taken care of. I mean, it should a card or a card should be made in which the child's dental visits for a year should be planned, and topical fluoride and sealant should be planned accordingly. Anticipatory guidance would be guiding the parents for what to expect in the developmental milestone and how they can minimize any kind of issues that might occur. And last but not the least is interim restoration. Now, use of SDF has been promoted in these cases along with glass ionomer cements. So SDF is silver diamide fluoride that can be used along with GIC glass ionomer cements in such cases that can leave the tooth pulpily uninvolved for a longer period of time. So there's a few guidelines for home care of differently abled children. The first one is wheelchair. If the child is on wheelchair, the parents or the guardians can sit behind the wheelchair. And firstly, remember to lock the chair wheels first, then tilt the child back into your lap, and the toothbrushing can be carried out. Since home care is of a very utmost importance here, the parents of the child are taught on how they can help in providing a routine for child's better oral care. A bed or sofa. Here the patient lies on the bed or sofa with head on the lap. It supports individual's head and shoulder with the parent's arm. The third thing is lying on the floor. Whatever is comfortable with the child, you kneel down behind his or her head. You can use your arm to hold person still. Beanbag chair. For the ones who are having difficulty sitting up straight, a beanbag chair lets them relax without fear of falling. Use the same position as for bed and sofa as well. And sitting on the chair, now patient sits on floor. You sit behind person on chair. Individual leans head against your knees. If individual is uncooperative or uncontrollable, you can place your legs over his or her arms to keep them still. Now, there's a few modifications of the toothbrush, especially in cases of cerebral palsy patients. Custom-made toothbrush is made in maintaining the oral hygiene and gingival health of the patient. The first one is handle modification of the toothbrush, handle and the shank modification. These are certain tooth grip modifications. Whatever suits better for the child is advocated. Now, this is Dr. Barman's super brush. Now, this super brush has 3 handles, and just by moving it, to and fro, all the surfaces of the teeth gets cleaned and has been proven to be useful in cases of children with special healthcare needs. Adaptation of existing toothbrushes by changing the size and shape of the handle will allow for sufficient grasping in patients with poor motor coordination or grip problems. For example, attach the brush to the person's hand with wide elastic bands or use Velcro fasteners. For people with limited grasp, enlarge the brush handle with a sponge or rubber ball or bicycle handle grip. For persons who cannot raise their hand or arm, lengthen brush with ruler, tongue depressor, or long wooden spoon. Use of electric toothbrushes have also been gaining popularity. A timer of 2 minutes and the child is good to go with the help of electric toothbrush. Obviously, it is dependent on the individual case selection. So, for example, who are able to cooperate, flossing can be carried out with floss holders. The use of antimicrobial agents, especially chlorhexidine mouth rinses, which we discussed in our preventive strategies, has been proven effective in reducing the severity of plaque accumulation and gingivitis. Now, the usual method of rinsing and expectorating is difficult for the persons with severe disabilities. Alternative methods such as application by swab or a spray is often indicated. Now, going on to what are the barriers to the oral healthcare, as I started the seminar with stating that dental care is the most common unmet need among the special needs population as given by Children's Health, National Survey of Children's Health. The barriers that we are facing are primary medical care system. Now, since the child has more urgent healthcare needs, oral health is given less priority, which is fine. But preventive strategies can make it better in a sense. Moreover, dental treatment may become more difficult with the child's existing medical condition. Now, lack of knowledge about oral and dental health is observed in underdeveloped or developing countries. So that has to be through various seminars or webinars. The lack of knowledge has to be lowered down in such countries. Insufficient dental school training education resulting in dentists who are not prepared or willing to manage these patients in private practices are seen. Generally, in private practices, if such patient comes, they are being referred to an institute or hospitals for the dental treatment. Financial limitations of parents already having medical consultations going on, it becomes hard for the parents to and becomes a financial burden for them. Additional time required for the treatment, it has to be taken according to the patient's comfort. So additional time is definitely required in such cases. Transportation difficulties can be minimized by making a certain clinic having grab bars or having a kind of facility that will help in transport of patients with wheelchair or such cases can be helpful. Pediatric hospitals imposed by age restrictions can create another barriers to care for these patients. Now, there are some ways we can overcome. We spoke about the barriers. How can we overcome? How can the children with special healthcare needs get a certain kind of how can we meet this dental need, and how the overall dental needs can be satisfactorily met without taking it to an advanced dental care. The first thing is starting early. Now, begin the oral care routine as early as possible is of utmost importance. Earlier the child becomes to gets accustomed to the dental care, it would be more comfortable for him in the future. Secondly, choosing right dentist. Generally, a pediatric dentist are trained and are experienced in handling such cases, not only pediatric children. The transition from children to adult A pediatric dentist takes care from through adolescents, including all those with special healthcare needs, whether be a children or an adult. Create a routine. Consistency here acts as a key. Establish a routine that includes all kind of home care routine, which we spoke of. For example, such as brushing, such as toothbrushing, mouth rinses, and use of fluoridated toothpaste becomes very important. The next is preventive strategies, which we spoke in detail. Teach and model. Watch and learn approach should be used in these cases. Visual demonstrations have to be proven to be very effective. In other language, we call it modeling. That can be used in teach and model scenario. Communication acts very important right from the start. The person who is handling special healthcare children needs to build up a rapport with the kids and be friendly with them all throughout their appointment. Sensory friendly tools. Now, for the sensory friendly tools, what can be done is usage of soft bristles toothbrush, kids friendly toothpaste, and specialized toothbrushes. Electric toothbrushes can be used in such cases. Anticipatory guidance, letting them know what they have to anticipate, and providing a good counseling during the journey is of utmost importance. Positive reinforcement. So whenever the child gives a positive response during this such cases, it is very important to give an award or reward the child to get a positive feedback, and as well as encourage the child to behave in the similar way for the next dental visit. Now, there are policies for children with special healthcare needs.
Dr. Yamshri, sorry for interrupting, but I would like you to wrap the session up as your time is exceeding. You're done with the 20 minutes.
Okay, ma'am. Just a minute and I'll be done, ma'am.
Yes, sure.
Okay, so Health Insurance Portability and Accountability Act. Now, this act helps in securing the privacy of the child, privacy and confidentiality of the child. The second one is AWDA, that is Americans with Disability Act, that avoids discrimination in the avoids certain kind of discrimination in the disabilities of the patient. The another one is policy on care, where failure to accommodate patients with special healthcare needs could be considered discrimination and a violation of federal or state law. Policy on emergency oral care was given by Council on Clinical Affairs that states the same. So to conclude, I would just like to say children with disabilities are like butterflies with a broken wing. They're just as beautiful as all others, but they need help to spread their wings. Despite the challenges, it is rewarding to raise awareness and provide quality care to the patients with special needs. These children also have the right to receive proper care, contributing to oral health. With tailored approaches, empathic understanding, and collaborative working, it is possible to overcome barriers and ensure that all patients receive the attention they need. These are my references. Thank you.
My name is Gabriel Rabayev. I'm a pediatric surgeon, and I work in Corporate University Medical Center in Astana, in Kazakhstan. The field of my work is pediatric surgical oncology, and today I would like to present you our research in the field of laparoscopic surgery in abdominal neuroblastoma. From our point of view, neuroblastoma is one of the best model in pediatric surgical oncology. This tumor can be very different and can be very different in as abdominal mass with different size and can encase different vessels in abdomen. So we can the surgeon can should to provide a different surgical approach to remove such tumors. It's important to remember that when we talk about neuroblastoma, we should remember that we don't need to achieve zero resection. The main aim of the surgical treatment is the resection of more than 90% of tumor mass, and it refers to improve the overall survival of such a patient, and the surgeon should ever, in every case, think first of all about patient safety and about patient safety. Here, I would like to present one case. What about we talk today? Here we present the case of 21 months old boy with retroperitoneal tumor, neuroblastoma, and this tumor has a close contact with abdominal aorta and left renal pedicle. When we're starting to remove this tumor, we should ever, in every case, remember about wide opening of retroperitoneal space, first of all, and about control of abdominal vessels. So we all try to provide our dissection plan with the careful control of vessels and other main structures in retroperitoneal space. So in this case, we talk about iliac vessels, iliac artery, abdominal aorta, and left renal artery. So you can see the main steps of this surgery. We provide dissection between tumor and abdominal aorta. And we, in every case, every minute, we control the position of aorta and how we can visualize the aorta in the abdomen. Now we dissect the tumor between tumor mass and left renal artery and renal vein. And after that, we will stop our operation and we remove all tumors. 100% of tumor was removed. And when we talk about classical indications for such surgery, we talk that the classical conservative indications are, first of all, small tumor size and the absence of IDRF. IDRF is image-defined risk factors. So IDRF is how vessels are involved in tumor process. But with the improvement of surgical skills, it becomes clear that these conservative indications require a revision. So I can to provide a very simple explain, and this explain is can be all can understand it. Involvement renal pedicle on the left side isn't the same thing that involvement of both renal pedicle, and this can it's really different difficulties for surgeon. Here I present one of the last Delta survey of a group of European colleagues, European surgeons, and one of the main conclusion of this study was that the precise role of each IDRF has been never critically investigated and need to be revised. For example, here I present a case of also retroperitoneal neuroblastoma with IDRF. The tumor was involved inferior vena cava and right renal pedicle, and we provide the same surgery as in the previous video, but we need to carefully dissect between tumor and inferior vena cava and right renal artery and renal vein. The main steps of such surgery was established by Kelly, English surgeon Kelly, in 2007, and for open procedure, and we use such approach nowadays for laparoscopic procedure. Here we can see one of the last retrospective study of European group of surgeons, CAPEN group. Now, in this study was enrolled 222 patients, and as we can see, 59 patients with thoracic and abdominal neuroblastoma who underwent minimally invasive surgery had presented IDRF, and 14 from them have one and more IDRF. So, conservatively, such patients should receive open procedure, open surgery, but they received laparoscopic surgery, and the main conclusion of the study was that the presence IDRF isn't absolutely contraindication for laparoscopic surgery. And when the patient presents one IDRF and a small tumor volume, we can provide such tumor laparoscopically. 2 years ago, we provide our study, our retrospective study, and we try to analyze our results in Dmitry Rogachev Hospital in Moscow. I should say that this research we carry out together with Rogachev Oncological Center in Moscow, and this analysis was provided together with Moscow and Kazakhstan colleagues. In this retrospective analysis, 124 patients were enrolled, and 26 patients from them have had IDRF, and 8 from them more than one IDRF. Also, with patients with neuroblastoma, with ganglion neuroblastoma, some of them have had previous open surgery and preparative chemotherapy. The main idea of this study was to understand how surgically difficult factors are associated with evaluation parameters of effectiveness of surgery. So we try to understand how presented on this slide surgically difficult factors correlate with operation time. And for this analysis, we use eta coefficient and Spearman correlation, and we found that 10 factors such as tumor localization, tumor the ratio tumor volume and patient height, previous open surgery, and involvement of some abdominal vessels are very close correlate with operation time. Using this data, we designed the pilot difficulty scoring system of laparoscopic surgery for abdominal neuroblastoma. It was possible for us, to according of summary point, to distinguish low, intermediate, and high risk group of such surgery. But for today, it's only preliminary study. We cannot recommend this pilot study for routine use because our difficulty scoring system didn't include all IDRF, all present IDRF, and there are some another difficulties that we would like to investigate in future. But what we understand that first of all, different IDRFs play different role in surgical difficulty and risk of laparoscopic surgery. Also very important that the ratio of tumor volume to patient height is much more sensitive risk factor than only tumor size. And there are some other difficulty factors that also play important role beyond only tumor size and IDRF. First of all, it's tumor localization and the previous open surgery, previous chemotherapy. And we understand that it's possible to design difficulty scoring system for laparoscopic neuroblastoma surgery. Using this data, we designed design of prospective clinical trial, abdominal neuroblastoma laparoscopic surgery risk factors stratification. The main idea of this study is also to understand correlation between list of laparoscopic surgery risk factors to results evaluation parameters. Here presents the study of this, the plan of this study. But for today, we are only at the beginning of our prospective research. For today, we have enrolled 37 patients in 2 centers, Dmitry Rogachev Hospital in Moscow and our hospital in Astana. From these 37 patients, 21 patients presented IDRF, and 9 patients had more than 2 IDRF. And hopefully in future meetings, we can present our new difficult laparoscopic system that we will can use as a routine practice. Thank you very much for your attention, and I will be happy to
This is me, Jennifer Alit Stephen, from Tashkent Medical Academy, Uzbekistan, and I'm here to present my presentation based on the topic precision vaccine program in pediatrics, enhancing immunization through personalized medicine. So basically, we are in our 21st century. So unlike the traditional vaccine program, we are moving on to the precision, like personalized vaccine program for all the age category. Basically, from childhood, we are taking this topic. So this is my topic. So, what are precision vaccines? Precision vaccines are tailored immunization designed to optimize the immune response based on individual genetic, environmental, and lifestyle factors. Unlike traditional vaccines, which are generally developed to be effective for the majority of the population, precision vaccine aim to account for the unique characteristics of different population groups or individuals. This approach leverages advancement in genomics, bioinformatics, and systems biology to develop vaccines that are more effective and have fewer side effects for specific subgroups within the population. So, what are the importance of vaccination? So, first important, the thing is prevention of infectious diseases. The second one is long-term health benefits. So, the third one is economic benefits. It is indirectly related to economic, which if the patient is having vaccinated, like even the child or the adult one, the economic status, like they do not want to spend money on the medications if they get or inside get an onset of an any illness. And the fourth one is social and educational benefits. If a kid is getting affected by any illness without taking vaccination, the education like the student can get holidays and all, so the educational all side is also got affected. And the fifth one is about the protection against emerging diseases. Then the last one is about the foundation for lifelong immunity, and these are the importance of vaccination. So the history and evolution of vaccine. So from early discoveries, starting from Edward Jenner and 19th century advances, 20th century progress, and recent developments, which we take vaccines for COVID-19, which went very drastic, like have caused so much of death in the world. So those vaccines are recent development. And if we come to the 21st century innovation, it comes to the precision vaccine, because each and every one is having individualized genetic genome structure. So each and every one will have genetic structure in unique way. So for those people, we are innovating our vaccines, especially for the children's. So that if the vaccines are specialized and if it is personalized, the side effects will be very less. So that is the innovation coming in the 21st century. So the traditional vaccination approaches, first it is about the live attenuated vaccines, especially for measles, mumps, rubella, varicella, and oral polio vaccine. The second is about the inactivated vaccine. For example, inactivated polio vaccine for hepatitis A and rabies. Third one is about subunit, recombinant, polysaccharide, and conjugate vaccines. Examples we can take as hepatitis B, human papilloma virus, Haemophilus influenza type B, and fourth one is about toxoid vaccines. Examples we can take diphtheria and tetanus. And fifth one is about mRNA and DNA vaccines, which is we almost everyone would have taken this vaccine, which is COVID-19 vaccine from Moderna and Pfizer BioNTech. So the principle, basically, these are the principles of getting the traditional vaccine. And first, it is about the unique genetic, environmental, and lifestyle factors of each patient, which is personalized. Second one, it is about predictive and preventive. It focuses on the predicting disease risk and implementing preventive measures. So when we take genetic makeup of one person, we can predict which disease can be caused to that patient, and we can take vaccines to prevent that before the illness starts. Third, it is about the integrative approach, which combines genetic data with clinical and environmental information to inform the treatment strategies. And fourth is very important, like patient-centered care. Here, the patients will be in their healthcare decisions, ensuring treatments align with their specific conditions and preferences. And fifth one is about data-driven. It utilizes the big data and advanced analytics to understand the disease mechanism and identify optimum treatment for the patient to get advantages to the most, not to get any side effects in their course of treatment. So the application in various medical fields. First, we take about oncology. Like it is a if we take for any malignant disease, obviously the oncology department can have like lots of death. So if there is any treatment related like precision treatments in this, we can save lots of life in that. So the targeted therapies here are so the cancer treatment that target the specific genetic mutation within the tumors. For example, the HER2 inhibitors in breast cancer. And in immunotherapy, if we are taking a personalized immunotherapy such as CAR T cell therapy, like in this CAR T cell therapy, we have taking the patient's like white blood cell lymphocytes directly from the patient, and we are fighting against the cancer which is developed in them. And the last one is about genomic filing, use of genetic tests to identify mutation and guide the treatment choices, improving the outcomes and reducing the unnecessary treatment to avoid the traditional treatments like surgeries. And then we go for chemotherapies. We can take the genetic makeup, like the entire profile of the patient, and we can move on to the patient's proper treatment, like which treatment is precise and which treatment will be effective without any obstacles caused to the patient in their outcomes, in their prognosis, like in which the patient will get very good prognosis. We have to take account into it. So second is about the next department like infectious disease, so vaccine development. So designing vaccines that target specific strains of pathogens, improving the efficacy and reducing side effects. So here mostly the viruses or bacteria is directly injected into the body of the patient, like in live attenuated form or in death form also, to activate the memory cells in the body to have, if the patient is having any exposure to the same pathogen again, the whole body will work against it and kill the pathogen. So that is a vaccine development. It is a basic criteria. And antibiotic stewardship using genetic testing. As usual, genetic testing will be done. It will guide the antibiotic selection, reducing the risk of having side effects and adverse reaction. And the next one is about the rare diseases. Like there are certain rare diseases like in tumors, like brain tumors, like cloud like which will be cost like 100 billion or 1 billion, 1%, like that kind of diseases will be there. So those people have genetic makeup very differently. So for them, genetic therapy are very important here. So gene therapy are done and the treatments are precise there. And molecular diagnostics using advanced genetic tests to diagnose rare diseases, which can be accurately and properly diagnosed, and the treatment outcomes can be started very easily. Next is about the like what is the ultimate considerations, like in children, the immune system, the unique considerations here. So basically, if we go into pediatrics, the patient have a very immature immune system, because pediatric, like if you take infants or people of young age around 16 to 18, they have like immune system comparatively less than the other adult people. So it will be in the developmental stage and immune response will be very low. And maternal antibodies will be there with them, and interference with vaccines. So next is about thymus activity, thymic involution. Like when the child is growing, the thymus size will get reduced. So the activity of thymus is also getting reduced there. and unique disease susceptibility. So they were exposure to the environment from others' home. So there are possibilities to get lots of diseases in this. And next about the role of genomics and personalized care here. So genomic sequencing, analyzing an individual's entire genetic code to identify mutation and variation that contribute the disease risk and treatment responses. Biomarkers, identifying the genetic markers that can predict disease susceptibility, progression, and treatment outcomes. Pharmacogenomics, studying how genetic differences affect an individual's response to drugs, enabling the selection of the most effective and safe medications. And in personalized care, we have electronic health records, clinical decision support, and research and development. So these are the results, like difference between the traditional and precision vaccine taken into account, like targeted population. In traditional vaccine, we design it for the general population, like almost it's very broad. And in precision vaccine, it is tailored to specific subpopulation or individual based on the genetic makeup. And second one is about the developmental approach. Traditional vaccine is developed using a one-size-fits-approach to all. And in precision vaccine, it is taken into account the detailed genetic and molecular data to address the specific immune system here. Third one is about the efficacy and safety here. Traditional vaccine or efficacy and safety are determined through the large-scale clinical trials, and in precision vaccine, it aims for the higher efficacy and safety within the targeted people. Uh, and fourth one is about the antigen selection, well-known antigens, of course, in traditional vaccines. And in precision vaccine, it is usage of specific antigen or combination that are most likely to elicit here. And first one is about the technological integration. In traditional vaccine, we use the live attenuated, inactivated, and subunit vaccines. And precision, we use the advanced technology like mRNA, recombinant factors, and personalized peptide vaccines. So the benefits here are like optimized immune response, targeted protection, minimized side effects, allergy and sensitivity consideration, immunocompromised children, genetic disorders and parental confidence, and simplified schedules, because traditional vaccines have like proper schedule of so much of vaccines, and when we go to the precision vaccines, the schedules are getting simplified here. So current challenges are vaccine hesitancy, like so much of population do not take vaccines here, and access and equity. Everyone will not have the accessibility to get the vaccine. Supply chain issues, emerging infectious diseases, evolving pathogens, public health infrastructure, age-specific challenges, safety and side effects. These are the challenges for this. And this is the precision vaccine developmental cycle. First, we identify the target population, which will be based on the genomic profiling and the environmental and lifestyle factors. And after once the pathogen got identified, the genetic and biomarker analysis is done, and bioinformatics is taken into account. Then the vaccine design formulation is taken into account, like platform selection and adjuvant optimization. And preclinical studies is done with in vitro testing in laboratories and animal models. First, we test in the animals and the clinical trials. So phase 1, phase 2, phase 3, and phase 4. So first 3 phases is done with small units and medium and large units of people. After compromising all these results, we take into account into the market for the surveillance, like whether the side effects cost or more or less. Then we distribute among the people. So this is the cycle of getting this. So ongoing research and projects related in precision vaccine programs. First, it is about the mRNA vaccines for cancer. So mRNA vaccines, we took it for COVID-19, and now it is taken into account for cancer. So it is focusing mainly for the identifying and encoding the patient-specific tumor mutation to stimulate a targeted immune response, like by our own cells. We are killing the cancer cells inside the body. And the AI and machine learning prospect is also taken into account, like integration of AI and machine learning to analyze the vast data sets from genomic studies and clinical trials. And last, it is about the global collaboration. So to increase the outcomes, there are collaboration between the international, like between countries and between states to find a proper program for precision vaccine. So the potential breakthrough will be more, and the outcome for the result, like if lots of scientists together work for this program, obviously the outcomes will be more here. So thanks for your attention.
Today I'm presenting a study I did with title The Intervention with Newborn Behavioral Observations in Newborn Infants and His Family, a scoping review. Brad Zoltan. Brad Zoltan developed the newborn behavioral observation as a tool for observation of the child behavior and support of the child development. The scientific evidence shows that the NBO promotes the safety, attachment, and mental health of parents and children. It was being used to supporting parenting during the first 3 months of life.
Ms. Patricia Martins, could you
Yes.
present the screen? It's not in the presentation mode.
Oh, sorry.
It's not in full screen yet.
Sorry, you can put my presentation.
I'm sorry, I didn't get that. You can try resharing the
Yes.
presentation maybe once.
You can see now?
It's still it's still not in the full screen mode.
Sorry, I don't.
May I suggest stop sharing the screen once and then reshare it again? Yes, now it's on. Oh, just on and it just went away. Yeah, it's all right. Yeah, you can share it again. Yeah, now full screen. Yes, perfect. Yes, kindly proceed. Yeah.
Wow. So, the objective, the aim of this study was to examine and map the knowledge about the utilization of the newborn behavioral observations in bio. The specific investigation areas are characteristics of NBO areas, outcomes, families' experience about the NBO utilization, and professionals' experience involved on this application. These two are carried out in accordance with the Joanna Briggs Institute according to 2015 manual by the PCC mnemonics. The study participants are newborns up to 36 weeks and infants up to 3 months of age, and their families who underwent NBO or cleanbus as an intervention in any context, hospital or community. Qualitative and quantitative studies and systematic reviews were defined on inclusion criteria. The search strategy was defined as studies published between 2006 and 2016 in English, Spanish, and Portuguese. The research was carried on in 3 stages as recommended by the GBI. 51 articles are found and 12 were included after analysis. A data extraction table was drawn out, which include data such as year of publication, country, objective, type of study, type of population, methodology, professionals involved, context, type of interventions, and outcomes. As for the results, it was found that the majority of studies took place in the USA, and most were published in the last 5 years defined in the search. Half of the studies were carried out in the child womb, 42% were carried out by nurses, and 25% were carried out by early intervention professionals, and 17% of the studies did not mention the professionals involved. 41% of the studies located at family interventions and others at high-risk newborns, at first-time mothers and health professionals, or high-risk newborns and first-time mothers. As for the number of interventions, half applied only 1 intervention and the others 2 or more interventions. After analyzing the studies, we conclude that the NBO is a flexible instrument that can be applied by many professionals in different contexts. It allows a bigger interaction between parent and child, higher self-confidence, satisfaction, superior child competence, and development knowledge by the caregivers, associated also a reduction on the postpartum depression and anxiety, enhancing to their relationship and confidence in the health professional. By professional perspective, involved in the NBO intervention, they also felt more self-confidence and with more knowledge on the intervention application. Of the implications for practice, we note that the NBO can be an effective intervention in enhancing engagement, encouraging maternal whole transition, and promoting attachment and bonding to be integrated in the health policies. It is implemented in 3 countries, United Kingdom, Norway, and Australia. These health systems are essentially based on the promotion of safety, attachment, and promotion of mental health for parents and child. This was the reference. And I would like to thank you for your attention and leave my email address available for any question. Thank you very much.